Okay, so some of you guys I may convince to go into pediatrics, medicine, some not. But no matter what, everyone's going to say, you're a doctor, yay, you're an MD. And so anytime I have some problem, like I am vomiting, blah, 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 I'm going to call you and I'm going to ask you medical advice. And of course you'll say, well, I shouldn't give medical advice to my friends and family, but they're going to push you and they're going to say, I'm throwing up, what should I take? So there's lots of things that people use. There's apple juice. In the hospital even, we still say ginger ale. Maybe they say chicken noodle soup. But the ideal method of rehydration should be something that is more isotonic than some of these options. So apple juice, for example, has only 0.4 milliequivalents of sodium. And its osms, as you can probably guess, is way high. So about 700. And Coke isn't much different. It's 4.3 milliequivalents of sodium. Gatorade, 5.9. Ginger ale, 9. Chicken noodle soup, you'd think have a lot of salt, but it's actually only 17. And then as far as their osms, Coke is way high too, 656. Gatorade's a little better, 377, so that's maybe why some people say to take it. And ginger ale is 565. So none of them are very great at having a sodium concentration or an osm that is close to physiologic. So in general, at least in the past, we didn't recommend these for rehydration. And certainly we don't still ever recommend them for serious or severe dehydration. An ideal oral rehydration solution would have a sodium concentration between 45 and 90 and have some chloride, have some potassium in it. There's a WHO one which tastes horrible. It has baking soda, but it's very useful, especially if you're in an under-resourced area that doesn't have a lot of IVs, for example, or that you can't access Pedialyte. Pedialyte has sort of been our go-to in most outpatient settings and in the ERs and sometimes on the floor, and is more ideal in its content physiologically. However, that being said, there are some new studies to suggest differently, which we'll cover. In general, when you're talking about oral rehydration, this only is for patients who have mild or moderate. Only mild and moderate dehydration. And generally, the way the textbooks will teach you is that you give somebody a trial. It's over 4 hours, for example. 4 hours is sort of arbitrary, but you give them a short trial of trying to take hydration by mouth. You still should calculate how dehydrated they are, so their percent dehydration, and again, this is their exam, and calculate their deficit. And then you figure out, basically in small amounts, and this is one of the ways that people at home often fail, or parents at home will fail, is that they're trying to give their kids cups at a time, maybe a cup of water every half hour or every hour, and the kids just vomit it right back up. So instead, tell them to try and give very small amounts over 5 minutes. So basically then what you do is you calculate your total volume of your deficit based on your exam, divide by 4 hours, and divide by 12, because it's 5 times 12 minutes is 60 minutes, so it's just a measurement of 5-minute blocks in an hour. So if you had like 1,000 mLs that you were trying to get into a child because that was your deficit, then you would divide that 1,000 mLs divided by 4 divided by 12. And you'd see it'd be just a very small amount of mLs. Now practically, especially if a parent's still at home or in the ER, you're not going to say, take 7 mLs every 5 minutes, so you might round up or round down to teaspoons or tablespoons. And then if they fail that, then they usually get an IV and get rehydrated. Now, practically speaking, and this is on record now, my husband as an ER doctor tells me we don't sit there and calculate, this number and divide by 4 and divide by 12. But what they do is they have a general assessment for how dehydrated a kid might look. And then they'll give them small increments of Pedialyte or apple juice and tell that, parent or child, if the child is older and doing it themselves, tell them to take small amounts frequently and see if they can do it. And if they can't, And if they fail, then they usually get an IV, or maybe they get some medications for nausea and end up getting admitted if they're not able to stay hydrated on their own. Alternatively, one thing that we don't do very much is that you can put in that lovely NG tube and put that, oh, this is a terrible NG, but anyway, NG is a way that you can actually hydrate a kid very well, and there are many studies with gastroenteritis suggesting that NG is actually better than IV for rehydration for something like gastroenteritis, but you won't see that used very often. Now, I used to give this lecture, and even up until a few months ago, was always telling someone, no apple juice, that apple juice is bad, or no Coke, that you have to use Pedialyte. Go buy that Pedialyte, or go buy those special popsicles that are some type of Pedialyte popsicles. But then there was an interesting study that actually just came out in 2016 that they actually compared in the ER dilute apple juice or preferred fluids to electrolyte maintenance solution, which is something like Pedialyte, and looked at treatment failure. This was a randomized controlled trial, and actually the kids that got the apple juice did better. They had less returns to the ER and less admissions. Now, they didn't look at, for example, BMPs in all these kids, or look at the hypo or hypernatremia in every child. Some of the kids certainly did get labs later, but these were kids that were, to remember, not severely dehydrated, and these were a lot of kids wouldn't qualify if they had comorbidities, so there were exclusion criteria to keep in mind too. But in general, in your fairly otherwise healthy kids who have, for example, gastroenteritis or vomiting dehydration, they actually did just as well in apple juice. So apple juice may not be so bad after all. Okay, so now you've calculated how much fluid you have to make up, and this is now going back to kids that are getting IV replacement. Although again, you could do NG, but you won't see that used very often, sadly. And you got to figure out how to give it. So the first phase here is your rapid phase. These are your boluses. And these are especially important for any kid who you're at all worried about shock. Or a kid even with moderate dehydration. So these, in general, are for your moderate to severely dehydrated kids. So the first phase is quick. Boluses are always quick, so they're over 30 to 60 minutes. And you repeat as needed. So if that child is still tachycardic, if their blood pressure is still low, then you give another bolus. And again, only bolus with isotonic fluids. Then your next phase is your rapid replacement phase. So this is over the next 8 hours. And during this phase, you're using maintenance plus, and here I have D5 half normal saline, but you could also scratch off that half, as we talked about before in our maintenance lecture, and use D5 normal saline, because that's just as acceptable now as D5 half normal saline. And so you're taking whatever that deficit is and giving half of it over the first 8 hours. So, in a child that you had calculated, for example, needed 1,000 mLs of deficit to make up, then if that child got a 20, let's say this kid is 10 kilos. If they got a 20 per kilo bolus already, then they already got 200 mLs given. So you'd subtract it from that 1,000 deficit. So you'd have 800 left to give. And so you'd give the first half in the first 8 hours, and the next half in the next 16 hours. So you're basically giving more fluids initially right up front in that replacement phase, and then once they're starting to stabilize more, you're backing off a little bit and spreading it over 16 hours. So this first 400 would be over the first 8 hours, so you divide by 8, and the next would be over 16. Plus, on top of that, you have to remember that every kid needs maintenance. So you're adding that maintenance fluid on top of that deficit that you calculated. And we'll go through some problems to discuss that too. So the way that I just taught you was the supposed right way, but there is a practical way that some of the residents use that I go over just so you know what they're talking about. Instead of doing all those calculations, which as you can imagine, get pretty complex, and you're having to do it over 8 hours and then put in a new order to switch the IV orders over the next 16 hours, what the residents do instead is they do 1.5 or what they call 2 times maintenance. So they calculate the maintenance rate. So say, earlier we did that 25 kilo kid, and your maintenance rate was, I think we calculated 65 mLs per hour. So instead, they'll take that 65 and they'll just multiply it by 1.5, and that'll be 1.5 maintenance. So they might say, oh, this kid, kind of in their head without actually doing calculations, this kid looks moderately dehydrated, so let's put him on 1.5 times the maintenance rate, so 1.5 times 65. Or this kid looks really dehydrated, let's do 2 times the maintenance. And it's not maybe as ideal, but it does tend to work out okay for most kids. That being said, you should be doing things like monitoring their eyes and nose, re-examine them, checking on their vitals, things like that to decide how you want to adjust their fluids according to how they're doing. So, for example, a 9 kilo kid, instead, if we use our 4-2-1 rule, they're less than 10 kilos, so it's just 9 times 4, so it's 36 mLs would be your rate, and then just multiply that times 1.5 or times 2. And that gives you how the residents often do it. That being said, I think even just if all you do is that first step where you actually even say, hey, I think this kid is mildly dehydrated or this kid is moderately dehydrated, I think that's a great start. If you just can even figure out this category and what their deficit is, you're off to a great start.